When Mauricio Ferrero first came to me with his discovery of the ESP block, I initially struggled really hard to understand how it worked. My regional anesthesia fellow at the time, Kareem El-Baghdadli, often tells the story of how one day I came into the lunchroom at Toronto Western Hospital and said to him, "Do you want to see some voodoo?" And then I proceeded to show him our early experience with the ESP block. Since then, I'm pleased to say that the voodoo has turned into science. And one of the nice things for me about the ESP block is how it has spurred investigation by lots of talented and curious people into the anatomy of the paraspinal and paravertebral area. And it's deepened our understanding of all the related blocks in this region of the body. One of the main controversies early on centered around whether the injectate spreads anteriorly into the paravertebral space, as we initially claimed, a hypothesis that was supported by several cadaveric studies, or whether injectate only spreads in the superficial tissues, perhaps involving the lateral cutaneous branches, which is what other cadaveric studies subsequently reported. However, this didn't match with what we observed in actual patients. This CT scan from our initial report shows that lateral spread of the injectate is limited, and more importantly, there was pain relief from what turned out to be a previously undiagnosed metastatic lesion in the patient's rib. This was what convinced us that there must be more than just cutaneous nerve blockade happening with the ESP block. And subsequent imaging studies in live patients have demonstrated that anterior spread into the intervertebral foramina and the paravertebral space can and does occur. What we now understand is that the gap between adjacent transverse processes is spanned by ligaments and connective tissue, which I call the intertransverse connective tissue complex for convenience. This is a porous, permeable structure of woven collagen fibers. In addition, this connective tissue complex is pierced by the dorsal rami of spinal nerves and their accompanying blood vessels, and this provides a pathway for local anesthetic to travel along. Our understanding of the thoracic paravertebral space and its communications with the plane under the erector spinae muscle has been further enhanced by this unique paper that was published just a few months ago. Cho and colleagues used sophisticated micro-CT scanning techniques to delineate the anatomy of this area. They confirmed a few things. First, the posterior boundary of the thoracic paravertebral space is not a simple, single, continuous layer of superior costotransverse ligament and internal intercostal membrane. Rather, there are multiple overlapping ligaments that span this area, the intertransverse tissue complex that I referred to in the last slide. Now, the two main ones are the superior costotransverse ligament, or SCTL for short, which runs between transverse process and rib, and the intertransverse ligament, or ITL, that runs between adjacent transverse processes. Secondly, the SCTL divides this paravertebral space deep to the erector spinae muscle into two compartments, what Cho and colleagues have chosen to call the retro-SCTL space, shown in green, and the actual paravertebral space, shown in blue. These compartments communicate with each other through a lateral and medial slit on either side of the SCTL. The medial slit is the gap that transmits the dorsal ramus. Here's a closer look at some of the wonderfully detailed CT images from Cho's paper, which are highly informative. This is a view of the medial and lateral slits, looking from within the thoracic cavity outwards. What I'd like to call your attention to is how the spinal nerve initially emerges from the vertebral canal into the retro-SCTL space, and it then divides into its ventral and dorsal rami within this retro-SCTL space. The ventral ramus runs anteriorly through the medial slit to enter the true paravertebral space, where it meets with the white and grey rami communicantes from the sympathetic ganglia, and then continues in an anterolateral direction as the intercostal nerve within the intercostal space. This is a parasagittal cut through the mid-thorax at the 4th and 5th costotransverse area. And we again see the retro-SCTL and paravertebral spaces divided by the superior costotransverse ligament, which has been colored in blue for clarity, with the dorsal ramus and accompanying artery within the retro-SCTL space, and the ventral ramus or intercostal nerve, on the other hand, lying within the true paravertebral space. Thus, if we perform an injection deep to the erector spinae muscle fascia within the ESP plane, there is no significant barrier to spread into the retro-SCTL space, where local anesthetic acts on both the dorsal ramus as well as the spinal nerve and dorsal root ganglion within the intervertebral neuroforamen. There can then be further spillage of local anesthetic through the medial and lateral slits into the true paravertebral space, where it can then act on the ventral ramus. These are a couple of other views that I find helpful in constructing my own 3D mental image of this anatomical region. The left-hand image is a cut looking in the medial to lateral direction, and the right-hand image is a plan view looking superior to inferior, similar to the center illustration. We clearly see the spinal nerve, dorsal root ganglion, and dorsal ramus within the retro-SCTL space. And we see the ventral ramus entering the paravertebral space through the medial slit to run forwards as the intercostal nerve in the intercostal space. Once again, local anesthetic injected into the ESP plane can spread freely into the retro-SCTL space to block the spinal nerve and dorsal root ganglion. And to a lesser extent, local anesthetic passes through the medial and ventral slits into the paravertebral space around the ventral ramus and spinal nerves. Here is the supplementary video material supplied by Cho and colleagues that illustrates these sections in sequence. It's important to realize that this second phase of local anesthetic spread through the medial and lateral slits in the SCTL is likely to be influenced by physical factors governing fluid dispersion, chiefly the volume injected and the dynamic compression and relaxation that accompanies respiration and other movements of the torso. Without these dynamic factors, the obstacle presented by the SCTL also explains why in some cadaveric studies of the ESP block, there is no staining of the ventral ramus. Now, this was put forward as evidence that the ESP block could not work as claimed. However, these same studies clearly show that the dye tracks along the dorsal ramus to reach the spinal nerve and DRG. Sensory afferents from the intercostal nerves and the anterolateral torso will inevitably pass through the spinal nerve and dorsal root ganglion on their way to the spinal cord. And so they can be effectively blocked here in the retro-SCTL space. This is not just theoretical or based off cadaveric studies alone. We can actually see this when imaging live human patients who receive radiocontrast in ESP injections. While much of the local anesthetic tracks into and stays within the muscle as shown by the density of contrast, a smaller but still significant proportion, as shown by the less intense signal, makes its way into the intervertebral foraminal areas, the area that we now know as the retro-SCTL space. And some of this injectate may even track into the epidural space. The fact that only a fraction of local anesthetic reaches the paravertebral and interforaminal zone also explains another controversial phenomenon, which is that assessments of cutaneous sensory loss over the torso are often patchy and incomplete. However, this does not necessarily indicate that local anesthetic did not reach the spinal nerves in the paravertebral space. Rather, it can be explained by the fact that the low concentration of local anesthetic here creates a differential sensory block to different sensory stimuli. This is a result of two other facts. First, that conduction block of nerve fibers is not an all or none phenomenon, but is proportional to the concentration of local anesthetic reaching the neurons. We're all familiar with this as block onset, or what we sometimes call soak time. The second fact is that different nerve fiber types have different sensitivities to local anesthetic conduction block, with the small unmyelinated fibers exhibiting the greatest sensitivity. What this means in practice is that pain relief, a diminution of perceived pain, can be obtained without losing all of the cutaneous sensation. And I think most of us at some point have reassured our patients undergoing surgery with local or regional anesthesia with the words, "You may feel some pressure, but you shouldn't feel any pain." And it's also why many studies differentiate between anesthesia and analgesia when assessing the onset and success of peripheral nerve blocks. The sensory loss usually progresses as the local anesthetic diffuses through the tissues and nerves with increasing concentration at the axons. However, if the concentration remains low, then the pattern of differential sensory block, which is often selective for pain, can persist, as has been shown in several studies. Finally, this action of local anesthetic in the region of the spinal nerve and dorsal root ganglion is also what can explain reports of effective analgesia with ESP blocks in purely visceral pain syndromes, including acute appendicitis prior to surgery and acute pancreatitis. I myself have since learned that visceral pain is not a sympathetically mediated phenomenon per se, but rather that the sensory afferents from viscera travel with sympathetic efferents in the same anatomical nerves and plexi, which is why a so-called sympathetic block, like a celiac plexus block, relieves abdominal cancer pain, for example. Therefore, the only place where a local anesthetic from an ESP block can possibly exert an effect on visceral pain is at the dorsal root ganglion and spinal nerve, where the visceral sensory afferents, which are the green lines in this diagram, converge with the somatic sensory afferents carried in the intercostal nerves and ventral rami, the blue lines. So what does this enhanced understanding of the anatomy and mechanisms actually mean for us in practice? Here are my personal takeaways at this time. First, that it's important to place the needle tip under or deep to the fascia of the erector spinae muscle, so that we're injecting into the retro-SCTL space, from where the local anesthetic can then spread and diffuse to the intervertebral foramen and the dorsal root ganglion, and perhaps even further anteriorly to the true paravertebral space. What we don't want is an intramuscular injection. Many of us who practice the ESP block thus no longer aim to land on the middle of the transverse process at a steep angle, but rather we insert the needle at a shallower angle, aiming for the edge of the transverse process. This allows us to skim off the edge and to go deeper if we're having trouble getting the needle tip under the sheath of the erector spinae muscle. If we enter into the intertransverse tissues, we're now approximating another named paraspinal block, the midpoint transverse process to pleura or MTP block. And the MTP block is another paravertebral by proxy technique, which has also been effective in early investigations. Another proposed modification is to use a transverse view instead of a parasagittal view, which makes it easier to land on the tip of the transverse process, and also to determine if the injection is in the correct plane rather than intramuscular. However, having said that, the second fact that has occurred to me is that it probably doesn't matter if you are a little bit lateral or medial to the tip of the transverse process when you're injecting. These images at two different transverse planes show you how the rib and transverse process articulate. The tip of the transverse process articulates with the tubercle on the neck of the rib. And you can see that what is labeled as the TP, or transverse process, in Cho's illustration is actually the base of the transverse process close to where it arises from the lamina. Injecting here takes you closer to the medial slit than injecting on the tip of the transverse process itself. And in fact, a more medial injection at the base of the transverse process has been advocated by Shibata and Ogoshi in what they have called a costotransverse foramen block. And we can now understand that what they call the costotransverse foramen is actually the medial slit that was described by Cho and colleagues. Based on their micro-CT scans, it appears that an injection close to the base or the takeoff of the transverse process will produce spread into the region of the dorsal root ganglion and spinal nerve quite readily, and possibly into the paravertebral space through the medial slit. A slightly more lateral injection at the rib transverse process articulation, on the other hand, will still fill the retro-CTL space, although further away from the intervertebral foramen. It is closer to the lateral slit, and this will potentially also allow spread into the paravertebral intercostal space. Without doing a formal investigation, it's impossible to definitively recommend being more lateral or more medial, but at this time, just based on the anatomical knowledge that I've presented, I think that erring on the side of being more medial may be preferable. The third thing to note is that the volume of injection is probably important to promote physical dispersion and spread of local anesthetic into the retro-SCTL space, and thus towards the intervertebral foramina. And it also won't hurt if we can get some to spread through the medial and lateral slits into the paravertebral and intercostal space. How much volume? Well, in adults at least, 20 milliliters is the most commonly studied volume and thus has the largest evidence base going for it. 10 milliliters may be the lower limit of effective bolus volume as suggested by this cadaveric study using endoscopic evaluation. Their data described a probability distribution of the injectate spread which confirms its variable nature. At the most consistent spread into the paravertebral space to all the cadaveric subjects in this case was seen at the level of injection, which was T5, and with the larger volume of 30 milliliters. The incidence of spread to adjacent levels fell off with increasing distance from the level of injection, as we might expect from the physics of fluid dynamics. There is also a fair amount of data from studies that use 30 milliliters as a loading dose and even 40 milliliters in a few reports. The most important thing to note is that these larger volumes will require the use of more dilute concentrations of local anesthetic to minimize the risk of local anesthetic systemic toxicity. They may also increase the risk of sympathetically mediated side effects like hypotension. I think it's not yet clear what is the sweet spot for volume and concentration. It may also depend on the patient. Anecdotally, older individuals, and perhaps too very young children, may have softer and more compliant or pliable tissues, and physical spread may thus be more pronounced in these populations, as you can probably appreciate from these videos. However, I must emphasize that we don't have systematic evidence for this as yet. Now, the relationship between volume and spread may also mean that programmed intermittent bolus regimens are preferable to continuous infusion through ESP catheters. This again is currently theoretical and anecdotal in the absence of head-to-head trials for ESP blocks. But having said that, here are 3 studies that compare PIB and continuous infusions with continuous paravertebral blocks in video-assisted thoracoscopic surgery, or VATS. And these have found that the PIB infusions can result in a larger area of cutaneous sensory loss to pinprick and cold. Not only that, in at least one study, they showed lower pain scores. Once again though, the optimal bolus volume and dosing interval is not yet clear for either ESP or paravertebral blocks. Although just looking at these 3 studies, perhaps the dosing interval as short as 1 hour combined with a reasonable volume of approximately 10 mils may be what is key to improving analgesia. Finally, we should have the appropriate expectations for the clinical effect of the ESP block. The degree to which the spinal nerves are blocked will depend on the amount of local anesthetic that reaches this area. And this is going to vary from patient to patient, depending, as we've said, on factors that may include their tissue characteristics, as well as technical factors in the performance of our block. We will probably not often see a dense sensory block, especially manifesting as cutaneous numbness of the torso. But patients can get analgesia in the absence of cutaneous numbness, and in fact, if we use more sophisticated assessment techniques such as quantitative thermal sensory testing, we found that we can actually detect changes in heat and cold pain thresholds that exceed that of conventional pinprick testing. What this means, I think, is that we should aim to utilize the ESP block as just one component of a multimodal, opioid-sparing analgesic regimen, rather than expecting it to eliminate the use of opioids entirely. On the other hand, this subtle, incomplete, and differential blockade of spinal nerves comes with unique benefits, namely a very low risk of sympathetic blockade and hypotension, and a similarly low risk of motor block if performing it for upper or lower limb analgesia. I'll end here by saying that I have little doubt that the ESP story will continue to evolve, and I look forward to having to update this presentation in the future.